Mobile device not found. Ready to pair.
Okay, we'll get started in a second. We're just letting everyone enter into the room. Okay, perfect. Good morning, and thank you all for joining us today. We're going to go ahead and get started on this final installment of our presentations on cultural adaptations. Thank you so much for joining us. We are so delighted that you have joined us. My name is Lauren Parker, and I'm a part of the leadership core and co-lead the Health Equity Task Force of the Bold Center of Excellence on Dementia Caregiving. Today's talk will focus on cultural adaptations for Asian American and Indigenous communities. The talk today is of extreme importance as these communities have distinct familial and tribal affiliations and linguistic traditions that may impact the use of dementia supportive services. Further, given the heterogeneity of Asian American and Indigenous communities, there is limited data on the prevalence and experiences of Alzheimer's disease and other dementias. As such, it is critical that public health agencies that are located in areas that serve these communities are mindful that the supportive programs are culturally adapted to meet the unique care needs of these communities. So our goal today is straightforward. We want to inform and to inspire you on ways to culturally tailor services to support the care needs of Asian American and Indigenous caregivers. So we are all together in this Zoom space, and I'm so glad we're all here. So in addition to the Zoom space, we can also have the conversation on Twitter. So please use the hashtag Culture Matters in Dementia to follow our conversation and keeping the conversation going. And while you're there using the hashtag, you can also follow us using our Twitter handle at PCO_DC. So you can stay updated on all of the different programs and services and future talks that we'll be having. So I keep saying the Bold Center, and the Bold Center is the program who is sponsoring and hosting the conversation today. The Bold Center is the Bold Public Health Center of Excellence on Dementia Caregiving. In addition to the Bold Center, we're also in collaboration with the Us Against Alzheimer's Center for Health Equity and putting on today's talk. So just a little bit of background for those who might not be aware of the goal of the Public Health Center of Excellence on Dementia Caregivers. It is designed to support state, tribal, and local public health agencies nationwide in developing their dementia-focused caregiving programs and initiatives. There's three straightforward goals. The first is to improve access to evidence-based programs and best practices. The second is to facilitate connections and collaborations between public health agencies and a wide range of service organizations. And lastly, what I think is really important is that we provide technical assistance for identifying, selecting, and implementing effective public health interventions and strategies. The talk today is just one of many services or technical assistance opportunities that we have. Please visit our website, connect with us to identify how we may be able to assist you. And while we talk about caregiving, there are a lot of different roles, we're really focusing on the informal caregivers. So those might be the family caregivers, caregivers of partners, those are the caregivers who our services are really designed to help. And we like to have conversations with all people, but we really want to focus our intent on informal caregivers. So I'm so excited. So this is our last presentation or installment in the Cultural Adaptation series, and the speaker list cannot be any more exciting. We are going to start our conversation off with Ocean Lay, who is the Senior Program Coordinator of the Diverse Elders Coalition. As a first-generation student of two immigrant parents, Ocean has experienced the linguistic and cultural challenges that many diverse older adults face, both in the US and abroad. He hopes to combine his knowledge and experience to spotlight and help change public perception and aging among diverse communities. Ocean has a master's degree in human nutrition from Columbia University Medical Center, and Ocean is also a member of the Health Equity Task Force for the Gold Center. After Ocean, we'll hear from Dr. Hera Han. She is the Associate Dean for Community Programs and Initiatives at the Johns Hopkins School of Nursing. Dr. Han's research focuses on improving health care for traditionally underserved ethnic minority populations by improving health literacy. Her transformational research has advanced thinking from the traditional paradigm of knowledge transfer from provider to patients to developing skills of patients to traverse the landscape of health screening and patient self-care to promote health equity. Through her work, Dr. Han has helped improve cervical cancer screening among African and Asian immigrant women and women living with HIV, and promote resilience and self-management among patients and families living with common chronic conditions such as dementia, diabetes, and hypertension. Dr. Han has received numerous awards from organizations that include the Urban Health Institute, the Southern Nursing Research Society, and the National Coalition of Ethnic Minority Nurse Associations, and the American Public Health Association. Dr. Han holds a joint appointment at the Johns Hopkins Bloomberg School of Public Health. After we hear from Dr. Han, we'll hear from Dr. Jolie Crowder, who serves as the Senior Project Director for the International Association for Indigenous Aging. Dr. Crowder serves as the Principal Investigator for the CDC's National Brain Health Initiative Award, designed to create a national hub for Alzheimer's disease and related dementia, serving Indian country, Alaska Native communities, and urban Indian populations. She also serves as a lead project evaluator for the U.S. Administration for Community Living Alzheimer's Disease Program Initiative awardees, who will be providing direct services, including evidence-based interventions to American Indian and Alaskan Native caregivers and people with dementia in Wisconsin, Oklahoma, and Arizona. Dr. Crowder also serves as a subject matter expert consultant to the CDC Cancer Prevention Across the Lifespan Tribal Subcommittee, working to explore the relationship between social determinants of health, resilience, and cancer within Native American population. And lastly, Dave Baldridge will join Dr. Crowder in having a discussion about the issues that impact Indigenous communities. Dave is a nationally recognized Native advocate for elder issues. Mr. Baldridge has served as the Executive Director of the International Association for Indigenous Aging since 2003. Prior to that, he was the Executive Director of the National Indian Council on Aging from 1992 to 2002. During that time, he published nearly 24 monographs and papers dealing with long-term care and elder abuse. Under his leadership at NICO became the nation's foremost nonprofit advocate for American Indian, Alaska Native elders. The organization tripled in size while significantly influencing the legislation and federal policies affecting Indian and Alaskan Native elders. We are so excited to have our presenters today, and we'll start off with Ocean Lay.
For the introduction, again, my name is Ocean Lay, and I'm the Senior Program Coordinator at the Diverse Elders Coalition, and my pronouns are he, him. About some of the unique issues of Indigenous dementia caregivers and Asian American and Pacific Islander dementia caregivers. Indigenous dementia caregivers. And when we mentioned Indigenous caregivers, we're talking about American Indian and Alaska Native caregivers. So a lot of this information that you see throughout many diverse from institutions and service providers. This may lead to a distrust.
Ocean, I hate to interrupt you while you're presenting, but it sounds like you're having some connectivity issues. So can you try one more time? We want to hear the wonderful presentation that you have, but we want to make sure that everyone can hear you. We can't hear you.
Can you guys hear me now?
Now we can. Thank you.
Okay, yeah. Sorry about that. These AirPods are very horrible. But yeah. So should I just restart this slide?
Yes, please, because we didn't hear you.
Okay. Yeah. So we'll begin with Indigenous dementia caregivers, and when we mention Indigenous dementia caregivers, we're talking about American Indian and Alaska Native dementia caregivers. And just as a side note, a lot of this information that you see in this presentation today, in my presentation, was gathered through the National Caregiving Research, the DEC, conducted with support of the Johnny Hartford Foundation. So one thing that is apparent throughout many diverse communities is a discrimination, negative experience, and neglect from governmental institutions and service providers. Particularly for Indigenous caregivers, this may lead to distrust of governmental institutions due to a history of poverty, displacement, and historical discrimination, which ultimately impacts their caregiving experience by making them more reluctant to use services, as stated by Sherlock et al. In fact, this was something we saw in our research play out. On average, American Indian and Alaska Native caregivers reported utilizing only 1.62 services from providers, whether it be for respite, transportation, care for health, etc. So you could really see some of the effects of that, at least in our research. Often this leaves American Indian and Alaska Native dementia caregivers less prepared for the caregiving role, which exacerbates the caregiver's burden, affecting their own health, and ultimately the health and well-being of their aging loved ones, being less prepared for the caregiving role, especially as dementia caregivers. Finally, I would like to mention, many American Indian and Alaska Native dementia caregivers also live on tribal lands or rural areas, making accessibility to services difficult, compounding caregivers' burden. So yeah, next we'll move on to Asian American and Pacific Islander caregivers. For Asian American and Pacific Islander dementia caregivers, there's also a lack of service utilization, but it may be for different reasons, at least what we saw in our research. For many Asian American Pacific Islander dementia caregivers, social and community support utilization may be nuanced by the impact of cultural and linguistic barriers. In our research, we saw that more than 1/4 of Southeast Asian American caregivers reported some or a great deal of difficulty with culture-related tasks. And by culture-related tasks, we mean overcoming language barriers, translating health information, supporting naturalization and immigration services for their aging loved ones. And so, yeah, a great amount of Asian American and Pacific Islander dementia caregivers are dealing with culture-related task difficulties. And we also, there are also clinical implications for this lack of accountability. In our research, we saw that diverse caregivers who reported some or a great deal of difficulties with culture-related tasks, as previously defined, had elevated levels of depressions and 4 types of strain. identifying Asian American and Pacific Islander dementia caregivers and asking these questions, because there are clinical implications. And this is, I also want to mention, this is also particularly troubling for first generation and second generation dementia caregivers, who may be limited English proficient and not proficient even in their own language. Personally, as an African-American Vietnamese adult, I have seen the results of these cultural differences and not accounting for them. Alzheimer's and dementia is often viewed as a catatonic disease. Personally, in the Vietnamese language, in my language, there's not even a word for Alzheimer's or dementia. So a lot of work needs to be done to resolve these cultural and linguistic issues among Asian American and Pacific Islander dementia caregivers. And I'll stop there.
Thank you so much, Ocean, for that wonderful presentation. And thanks to everyone for your patience as we're all navigating the Zoom world. So next, while Dr. Han is pulling up her presentation, I just want to have a quick reminder, and I didn't say this before, we're utilizing the Q&A button at the bottom of your screen. So if you have any questions, please feel free to send questions via that feature, and we'll be able to answer it during the presentations. And also at the end, we'll have times for Q&A. So at this time, I would like to thank Dr. Han for her presentation.
Thank you so much for the invitation. I'm so happy to be here. I will talk a specific case of Korean Americans following Ocean's great presentation in delivering and implementing dementia caregiving specific intervention programs. Just wanted to share my disclosures. So to add on some of the information that's been shared, Asian Americans in general in the United States are growing really fast. This is a latest information, a piece of information that was published a few months ago. We just had our Census 2020 data came out. According to some of the information at the national level, Asian Americans represent the fastest growing racial and ethnic minority group from year 2000 to 2019. We had a growth in the 81% as opposed to 70% for Hispanic, 61% for Native Hawaiian and Pacific Islanders, and then 20% for Black Americans, respectively. So obviously, Asian Americans, the size of this group is increasing really fast. It is a very diverse group. You just heard from Ocean that he's Vietnamese. Myself is Korean. There are 3 other major countries of origin. However, altogether, there are more than 20 different countries of origin within the Asian American population. Another key aspect of Asian Americans in the United States is that this is the group that is overrepresented by immigrants. So you can see that more than 2/3 of Asian adults in the United States now were born in another country, as opposed to 17% of the general American adults. So I think Ocean also mentioned about linguistic barrier that is real. This is a big problem in designing and implementing, or issue rather, I take it back, issue that we have to consider. Asian Americans are projected to become the largest immigrant group by year 2055. And 2/3 of Asian Americans today speak a language other than English at home. So this level of immigrant population, as well as the language spoken at home, limited English proficiency, has a dire implication in terms of health literacy, overall access to care. So let me talk a little bit more about Korean Americans in particular. As I highlighted earlier, Korean Americans represent one of the 5 largest ethnic minority groups within the segment of Asian American population. Currently representing 9% of the whole Asian American population. The size is close to 2 million. It is not easy to find prevalence data on any Asian Americans in terms of dementia. However, our team was lucky enough to be able to got some funding from the Alzheimer's Association some years ago, and were able to conduct large-scale community-based assessments At the time, we tried our best to include both mobile older Americans, older Korean Americans, as well as immobile who are basically homebound in adult daycare and other settings. At the time, we found that 20% of participants had some form of cognitive decline based on mini mental state exam, as opposed to 6 to 13% reported at the national level. And at the time, our suspicion was that it might have had to do with a higher level of high blood pressure, uncontrolled high blood pressure and diabetes. But I can just say that that was just one study, so just wanted to give that caution. We, through other investigations, learned that Korean older adults are heavily dependent on informal family level caretaking. Because of limited language proficiency, as well as lack of awareness of all these different resources that are available. It is quite uncommon that Korean Americans in general utilize formal care resources. And in return, many times people rely on their family caregiving, if not through friends and relatives. And this brings about a lot of issues you can imagine amongst family members and caregivers in terms of their mental health status as well. So all in all, we, through a number of studies, showed that this population, Korean Americans, are characterized as having under-resourced and underserved population in terms of dementia care. So what are the specific issues? As I mentioned previously, there is lack of Beijing knowledge about diagnosis, treatment, and cause of dementia. And study after study, we learned that most people, Korean Americans, do not know some of the basics about dementia, and many think that dementia is just normal part of aging, so you don't do much, even when you see some of the signs and symptoms of dementia. Until there is some actual health hazard that occurs, only then oftentimes families bring their older adults to see their doctors in a hospital, and then go from there. By the time it's a little too late, because it becomes a full-blown dementia. And because oftentimes dementia is interpreted as insanity, it's sort of a mental health problem, and hence in the community there is this large stigma, feelings of shame associated with this diagnosis of dementia. And then another issue, again, going back to the issue of limited health literacy and limited English proficiency issue, at the national level, we know that mental health providers, the size of it is not really enough to cater to all the needs that are growing. You can imagine in a linguistically isolated community like Korean American, the number of health providers who can provide culturally and linguistically appropriate dementia screening and care is even smaller. So there goes this issue of lack of diagnosis and follow-up care. So altogether, our team decided that we need to do something about this. So we developed an intervention called PLAN to focus on dementia literacy and a linkage to care services, so that we can promote dementia health outcomes in general. So the purpose of my presentation is really to discuss our research endeavors briefly, and then also to share key lessons learned from our intervention development processes. So this is the study team. Our study plan is dementia literacy education and navigation for Korean elders with probable dementia and their caregivers. I was running out of space, so I couldn't put all the photos of my study team members, but here are some of the key personnel. The plan intervention is community health worker-led intervention, and I'll explain briefly later as to why we decided to work with community health workers in delivering this intervention. We focus on dementia literacy education as a way to really leverage the common language education so that the study population can understand the issues around dementia in general, and then help them go through the healthcare system to establish dementia evaluation and then development of care planning. This in return eventually would improve caregiver outcomes, addressing self-care, self-efficacy, knowledge, dementia literacy, as well as their mental health outcomes, including depression and stress. So to share some of the main themes we learned from our pre-intervention inquiries using survey and focus groups, there were 3 key areas that we needed to focus on. So the first one was linkage to care. And oftentimes we heard that a functional decline was a common reason for caregiving, but the majority of our caregiver participants noted that they had a limited awareness and access to care to provide any sort of dementia-related services. So there was this, another one was health literacy. Through our investigation, we learned that Koreans in general have high level of education, but if you come to a new country where the language is not your native language and you have to learn the new language skills anyways, and yet it's not the same that, you know, the language skills you get directly translate into high level of health literacy, because health literacy is really specific to health areas and arena to understand and verbalize health related information and then really adapt that information you understand into action. One of the quotes we got from a participant says exactly that. So the educational part is so way over their head. It's just up there. You follow me? It just needs to be real basic, plain information. So the focus on health literacy was really an important aspect of our intervention development. And also in terms of community outreach and navigation assistance, because a lot of Korean American caregivers face double challenges. One, they have to settle in a new country in the United States, while also fulfilling their cultural filial piety called hyo, which means you take care of your parents when they get old because they took care of you when you were young with love. So you need to return the love and care that you received as a child to your parents. So a lot of Korean caregivers share their struggle between the reality that they have to deal with on a daily basis as a new immigrant and fulfilling their filial piety that is required by the cultural belief. So these are some of the pictures that we took during the intervention development process. I want to share main findings from the pilot, which includes community health worker successfully provided our planned intervention that increased linkage to care, improved caregiver outcomes, and the satisfaction was really high. 100% all of our caregivers participating in the pilot said that they would recommend the program to others. And we also achieved 100% retention rate, even though it was a brief intervention delivery for over 3 months. We are now running another efficacy trial to look at the outcomes over 6 months instead. These are some of the quotes from post-intervention interviews. You can just read the ones that I highlighted just to show how the study participants felt about the use of community health workers in delivering this intervention to promote dementia literacy and linkage to care. One of the study participant, caregiver, daughter-in-law, said that I began to accept that meaning dementia might be a new normal for her. She couldn't understand before she joined the study why her mother-in-law is showing some of the symptoms. Now she does, and she was basically accepting that this is a new normal for her, and then she said she's going to adapt to the situation. A husband caregiver said it was really important that the community health worker called me on a regular basis and then checking to see how I was doing, to see if I have any issues. Eventually, the husband caregiver was able to help the wife who had dementia to get the diagnosis confirmed and then develop the plan of care afterwards. We also included a church friend as one of the caregivers, and I'm gonna talk briefly about this caregiver issue in a different slide. But the church friend said that I wanted her to see her friend to see a doctor, but she couldn't because of her insurance problem. Many of you might know that because of the Medicare Modernization Act, I believe, back in 1996, unless you have points of full-time work over a certain time period, the type of insurance, a public insurance program option is really, really limited for older adults who haven't worked here in the United States. And she was exactly, the church friend was exactly that issue, was experiencing this issue because she did not have any health insurance at the time. So key lessons learned from this investigation, we learned that caregiver trust in community health worker made a huge difference, and their knowledge and understanding of the topic also were highly appreciated. And caregivers stated that they appreciated the length of time allowed for questions and answers through phone calls on a regularly based. And navigation assistance were proven to be a key factor in our caregivers to obtain the resources for dementia evaluation and care later on. So I know our next speaker is going to talk about stakeholder engagement, so I'm not going to talk too much about this, but I believe our intervention has been successful because we really tried our best to engage our end users, stakeholders in the intervention development processes. And these are some of the thoughts for many of you who are thinking about adopting or implementing or designing intervention programs involving older immigrant populations. I believe that incorporating essential health literacy skill set, in this particular case, dementia, but in other cases, the study or research that has been conducted so far have shown that health literacy skills can change. You can actually promote health literacy. It's not a trait that doesn't change. It actually can change. So incorporating some aspect of health literacy skills training into the intervention program is really important. Now we are facing this era of 21st century telehealth and all the digital technology. Are we really incorporating all these new technologies in helping our caregivers? For one, in our current trial, we're experiencing a lot of digital literacy issues. Even when we try to screen for MMSE amongst our older Korean Americans, many times we hear people don't even know what an app is, how to download Zoom to be HIPAA compliant in doing research activities. So the strategies to address limited health literacy is going to be even more important as we continue on. And then health problems that our first generation and immigrant populations overall experience intersect with health social factors in the absence of a usual source of care. And also briefly, caregiving, we would anticipate that any older adult would have some caregiver or caregivers to identify. And yet, in our actual recruitment activities now, we come across multiple challenges in identifying sustainable caregiver because oftentimes immigrant older adults do not have viable caregivers who can support any endeavors like this. So that was one big issue that that is still a big issue that we're interfacing right now. And then also transportation. It's not a new piece of information. However, we also see this transportation issue becoming even more important now that we're trying to bring in some of the older adults and their caregivers to our community site location for screening as well as data collection and intervention delivery. So when we work with immigrant populations, especially Asian Americans, where immigrant population proportion is really high, consideration of some of these social factors will be really, really important. I think my time is up. Thank you so much.
Thank you so much for that very informative presentation, Dr. Han. And I really appreciated the quote at the end that you had. So next, I'll turn the floor over to Dr. Carter and Dave to present on issues and considerations in American Indian, Alaska Native communities. I think that you might be on mute, Jolie.
Unmute. I'm sorry. Thank you. Dave, were you able to get your audio connected? Maybe not. All right, well, we will just press on. Thank you so much, Dr. Hahn and Ocean, for your presentations. I think there's a lot of commonalities between your findings and populations, though I think, the approaches, I believe, is where the rubber hits the road, where things probably differ a little bit in how we engage with the community. So I really appreciate those insights. I'd also really like to extend our appreciation to the Bold Center of Excellence staff for inviting us to be part of this great series. I've watched all of them and found them great reminders and great opportunities to learn some new things. And on behalf of both myself and Dave, who's the I2 Executive Director, and my amazing mentor, we'd like to extend our thanks to the folks who are on the line for granting us the opportunity to share some of our experiences with you guys today. There's a lot on this slide, but that means that you can keep busy reading, and I'll talk pretty briefly about this. About 8 years ago or so, I2 staff began working closely with the Alzheimer's Association and some other agencies on the issues of Alzheimer's and dementia. This was part of foundational work funded by the CDC Healthy Brain Initiative. You can see a variety of the activities that we participated in up to today. In fact, it really started with outreach and engagement in communities, discussions held with elders, aging services providers, tribal leaders, and others, which was the foundation for the Roadmap for Indian Country that was published a year or two ago. Also, I would just point out on this slide, if you aren't aware, we have a pretty robust suite of materials that we created in conjunction with the folks at ASTO, with funding again from the CDC, called Healthy Heart, Healthy Brain. They've since been adapted by the National Council of Urban Indian Health and Alzheimer's Association, different look and feel and a little bit of different language. You'll find on our website, ainbrainhealth.org, you'll find flyers, posters, PSAs, and video stories from caregivers, as well as the most popular downloaded resource, which is a healthcare provider talking guide that discusses connection between heart and brain health. So I encourage you to take a look at our website. We also have a new resource library with additional population-specific info. We were very fortunate to be funded by the CDC Healthy Brain Project. We have a 5-year award. We're just starting year 2. We're the only national project funded under BOLD or Healthy Brain, focused on adapting and creating information resources for American Indian and Alaska Native populations. And even though our charge is to serve a national audience, our approach is really based on engaging with communities and placing an emphasis on locally tailored and culturally relevant resources in the space, knowing that without that they're less likely to be used in those communities. You can see the 4 main objectives that we have for our project. And I think primacy definitely goes to number 1, which is advancing community engagement and helping build capacity to help them serve elders living in their community. We also are interested in taking a lifespan approach, so not just focused on, the elder population at the right half of the aging spectrum, and then have interest in creating dementia-capable communities and promoting the Roadmap for Indian Country, which, if you haven't already picked up on it, is a pretty great document and resource. And if you desire to work with tribal communities, that might be the first place you look to help start educating yourself in this space. Our value statement is the smallest font on there, but I would say probably the most important. And that really does guide our day-to-day work. And at the core, emphasizes and recognizes the promotion of tribal sovereignty and advancing our work in community populations. This slide gives you a glimpse of our National Multidisciplinary Advisory Group. This has really been a fundamental intervention and focus of our efforts in year 1. The advisory group includes both consumers and caregivers, and it's a way for us to engage on 2 fronts. One, they help us in guiding our project activities and providing feedback on information resources, but they also in turn serve as a conduit for information and resources once they're developed. And so Our discussions with the group over the last year, both in our formal meetings and in between, have been super helpful in guiding our work and direction on the project, but they also really help us gain perspective on bigger systems issues that we need to think about in the course of our work, as well as just serving as an ear to the ground in this particular space in their communities. A little bit of information. I cut a lot of this. I know hopefully some of you folks were able to attend a presentation we did last week or the week before, where we were able to talk more in depth about the American Indian and Alaskan Native population. I've got a couple slides in here, but most is really focused on some implementation efforts. It is important, I think, for us to talk about a few cursory points and how dementia plays out in the American Indian and Alaska Native community population. In the general population, I'm sure you've all heard that it's estimated that 1 in 9 people over 65 years of age are living with dementia. And the largest, and I'd say bias, in my bias, though, probably one of the best studies to date found that 1 in 3 American Indians 65 and older were projected to develop dementia. That study is about the best we have, in that it did a really great job of identifying folks by race as American Indian and Alaska Native, and it was a longitudinal study over the course of 10 or 15 years that tracked the development of the disease in the populations that they looked at. Incidence and prevalence data is scarce, to say the least, for American Indians and Alaska Natives. Though practically speaking, we've heard over and over again from elders and caregivers to providers that underdiagnosis is a problem in tribal communities. And so you can imagine relying on existing data sets or systems that measure the case counts of dementia or Alzheimer's or other types of dementia. For instance, Indian Health Service or Medicare, we're not going to really get a true picture measure of the extent of the problem. Also, given the most recent census updates, which showed the American Indian population almost doubling, you can anticipate the actual number of elders will be higher as well. And according to previous census data, Native elders are in fact one of the fastest growing minority populations. And I think Dr. Han talked about the Korean American population. Pretty much all minority populations are outpacing growth in the space. Urban migration, another, I think, important consideration in your work is where elders and their families are located. We historically think of Native American people living on reservations in certain sections of their communities, but the reality is that the majority of people who identify as American Indian or Alaska Native now live in urban areas. It's a hard population to access. Urban Indian organizations that are funded by Indian Health Service really function as more of safety net providers in the few communities that are lucky to have a UIO in their area. This urban migration.
Jolie?
Yeah, Dave.
This is Dave. I wanted to contribute. One of my longest time colleagues, Dr. Mario Garrett from San Diego State University, has called the Indian urban migration the largest ethnic migration in America's history. We've now got 70% of our population living in cities, while unfortunately services through the Indian Health Service and others continue to be directed to tribes where they are available. Thanks.
Awesome. That's great. And I'm most excited, Dave, we got your audio working, so that's awesome. We could probably talk at length about the history of atrocities that have occurred in the population. Most recently, one might consider, the emphasis for this move, this migration, which really dates back to a federal policy in '53 that was, the goal was to terminate the sovereign rights of tribes by moving them off their lands and weaken the strength of the tribal communities. In '53, 8% of American Indians lived in urban areas. And as Dave just talked about, now that number is closer to 70%. The folks, when we were prepping for the call, asked us to share things that we think are most unique besides the facts and figures that I provided. Everything might be a bit of a stretch about how the population differs. but maybe not too far off. I think you've most commonly heard discussions about difference in culture, belief systems, spirituality, social determinants of health, rurality, almost any variable that you can come up with. There's likely a difference between American Indian and Alaska Native populations and the mainstream population. When pushed, I think I would point out the three biggest differences that make them unique. In public health, the most significant differentiator and the thing that folks often seem to forget or miss in their process of learning about tribal communities in their states or locales is that tribes are sovereign entities. That means they are themselves their own government. And for federally recognized tribes, there is a government to government relationship that exists both at the federal and state level. They're not just another neighborhood that happens to live within your locale or your state. I think second,
under the federal trust responsibility, Julie, tribes essentially have the same status as states, and that they're self-governing, and it's the only ethnic minority that has a direct relationship with the U.S. government. Thank you.
No, that's great, Dave. That actually flows really well into the second point about the federal trust responsibility. And that trust responsibility means that the federal government has what's now a long-standing legal obligation to provide care and other services for tribally enrolled members. And that doesn't just apply to the folks who reside in tribal lands. It also extends to folks in urban areas. The final point is about the complexity of the healthcare system. At this point, 60% or so of tribes have opted to manage their own healthcare. 40% is run by IHS. What that system looks like and how it interfaces with other elements in the surrounding healthcare system is unique to each tribe and something that's really important for you to understand capacity and resources that are available. I think, in our prep for the roadmap and our work since, we've learned 3 or maybe 4 really important lessons. They're actually, I think when Dr. Hahn was talking about sort of their background work and what they identified, you're going to see a lot of similarities in this slide and hers. I think one difference, and this may or may not be the same, but in most American Indian and Alaska Native communities, the focus really needs to be at the community level. In terms of belief systems and where they believe resources and assets lie, are focused on the good of the community and the whole of the community. I think we have the same issues of awareness, although I think we found in our outreach that most communities are aware and concerned, and elder advocates know it's a growing problem. But I think their understanding is very fundamental. They lack knowledge about what dementia really means, what Alzheimer's really means, and how that plays out. The big but here is that few tribes or communities have programs in place to help people living with dementia or caregivers. I think, again, that's another similarity with the Korean American population. As with other populations, and perhaps more so in Native communities, we've heard from just about every source that we've spoken to that whether it's fear, denial, stigma, or access, that very few people in tribal communities have a formal dementia diagnosis. And when you're in an isolated or rural tribal community where folks often know each other, lack of confidentiality is a pretty sensitive subject. In these communities, IHS urban or tribal programs are few that can diagnose and access dementia or address dementia caregiving. And then providers in the system lack knowledge and sometimes confidence to be proactive in addressing clinical issues in this space. And time is really a luxury in this system. One IHS doctor told us that his clinic was so underfunded and he was so overworked that he just couldn't take on any new mental health issues. The tribal health system was originally designed as a public health system, and the manifestation has been equal clinical and public health care, but it's really unlike any public health system in the traditional sense. I think we heard from our friend and colleague at the Indian Health Service that mainstream isn't always the model in Indian country, and it's like putting a square peg into a round hole. There are a number of approaches that we could recommend as models that you might consider, but the foundation of all of these is really a commitment to long-term engagement, whether it's community-based participatory approaches or authentic partnerships. All of these center the community's expressed needs as the priority, and that takes precedent over any external metric or goal that you might create on behalf of that community. We've talked about the immense diversity, and each of the tribes that you might work with vary from one to the next. And the urban population is even more diverse and often overlooked in this space. One size fits all thinking doesn't apply. We encourage you to authentically engage with communities. You need to go to them where they're at. You need to respect their rights as sovereign governments to inclusion, though, in your work. Remember that public health policies and protocols are very different, even within your own state. And to be most effective, you need to address them one tribe at a time and work to understand their protocols and questions. And then, as with any partnership, I think you need to give more than you take. I've got a few examples in here, but I know we're running short on time. But I would offer that we've done a number of things, even in the first year while we were building partnerships and relationships, one of which was the Dementia Friends. Many of you may be familiar with that program. It requires a license to implement, and the focus originally was on increasing awareness and reducing stigma. USA Aging was kind enough to allow us the opportunity to adapt materials for use in the American Indian and Alaska Native population. And we really worked to put practices and principles of community engagement into this effort. We convened a work group of end users that included 10 people from across the country and multiple tribes. They gifted us with a total of 12 hours across 3 sessions of their time, which equates to about 120 man hours into making revisions. After the first significant round, we then took the workbook to our national advisory group, another subset of the population, and then their allies. And the output was another 10 hours or so of revisions to content. We turned it over to USA Aging, who is the license holder, and we were really fortunate that they warmly embraced all of our recommendations. Then we took that version and we piloted the revised training and workbook with American Indian and Alaska Native people, and then revised it again. As you can imagine, it's a labor and time-intensive process, but the overall output was great. This is a list of all of the changes, or summary of the changes and types of changes that we made in the content. There's a lot of culture, there's a lot of resiliency, there's a lot of reframing, and a lot of simplification of language. There's a couple other examples. Savvy Caregiver for Indian Country has been adapted. Dr. Henderson has talked about that. I think the big takeaway for his work in that space was classroom stuff doesn't work. They want to talk to people sitting in their homes on their couch to learn lessons. We also have more recently been working on an adaptation of the 10 warning signs brochure that you can see here has gone through a few stages. Again, this has taken hours of work with people, by people, to make the words their words, to eliminate words like hygiene that not everybody will understand what that means. So we did more recently, we incorporated some questions that we shared with our advisory group as they looked at that flyer, and asked them specifically to think about these dimensions. Half the group got one model and the other got another set of questions to consider. And we're sort of tooling and retooling the way that we work on adaptation of materials. So I'm done. I think Dave had some closing thoughts. There's other slides. I've got 5 or 6 resources on a slide about cultural adaptation, and then info about us. So Dave, do you want to just close us up?
No, sure. Thank you, Jolie. I'd like to just offer a short blessing to finish up our presentation. Ogidada, great one. We're thankful for Mother Earth. We're thankful for Atsela, the fire of life. Gift us with healing and the ability to be helpers to others as you would have us be. Wado. Thank you.
Thanks so much, Dave. Sorry if we went over, Lauren.
It's okay. Thank you so much. I mean, every time we have one of these talks, it's like we could go on and on and on and on. So I'm just so thankful for all of the presentations. Dr. Hahn and Ocean, if you would like to come on. We don't have much time, but I'll try to get to as many questions as possible. And then a number of people have asked, do we have time? Are we going to be able to send out the slides? Yes, we are. So the slides that Jolie couldn't get to and any of the additional questions that you have, we will be able to answer it from there. So I'm just going to get straight to a question. One of the questions, and this is for Dr. Hahn, is that, is there a movement currently to disaggregate AAPI and Alzheimer's and dementia research? There is such a diversity, as Dr. Hahn mentioned, that cultural adaptations cannot be based on AAPI data at large.
Thank you for that question. I don't want to sound like a broken record. We've been asking for data disaggregation for how many years, as far as I can remember, but it's not still happening much. I think I also saw one of the questions through the Q&A. Someone asked whether state-specific disaggregated data will become made available for Asian Americans. It will. However, it's not going to be made immediately available. That's usually another problem that we have to face when we try to work with certain groups of population because of the diversity, even within Asian subpopulation. It's really hard to get the kind of data that we need. And I think whenever there's an opportunity, we just have to, speak up and then ask for data disaggregation. Unless data is available, how can we make a problem and then, do the management of those issues? So that's a great point, but unfortunately, it's not happening at the speed that I would like to see.
Yeah, that's unfortunate, but hopefully we can be advocates in our local community and reach out to policymakers and state representatives to see if we can push for that. I'm going to ask a quick question for Dr. Potter. Is there a list available for dementia-capable Indian communities?
Well, I can tell you it's probably zero or not very far from that. There are really initiatives just getting underway in most communities. The one that I'd say is probably like the most furthest baked initiative would be in Nevada. Paiute Lake Tribe there has been part of the state's Dementia Friendly Community Initiative and tied in with that and gone through training. But even at that, I think they really struggle locally with resources to focus. There are some ACL grants, Alzheimer's Disease Program Initiative grants, and there's 4 tribes funded last year in Wisconsin, North Dakota, Alaska, and Oklahoma. And then one more tribe received funding this year, and then Wichita affiliated. And so I'd say of tribes, those are probably the ones that are going to have the most solid, significant initiative in this space. Otherwise, it's just not quite as far along as the rest of the country in this space.
Okay, thank you. I so wish that we had more time to ask questions and dig into everyone's mind, because everyone who presented today is such a wealth of information and a great resource. So I hope that the participants are able to glean from the slides. And I'm sure if people have direct questions, you all don't mind if they reach out to you via email that you've shared. Yeah. So once again, thank you so much for everyone, for the presenters and those who have attended. This is very important to think about the communities that we mentioned. You all will be sent an evaluation survey. If you can please take part in this survey and answer some questions for us so we can continue on with offering programs such as the one we had today. Thank you for your time. I hope that you all stay well and take care of yourselves during the COVID pandemic and also throughout the rest of the year. Thank you so much.
Thanks so much. Bye-bye, everyone.
Bye.